Good morning.
Okay, I think we have just about everyone. All right, so today we're going to start with our GU system. Not a very long lecture. We'll take a quick break and then we will use the rest of our class for review time. Okay. I'm sure it's no big surprise. We have our exam tomorrow, first pediatric exam. So what we'll do in our review, I have it set up like kind of review questions. I know a lot of students really like, what is it? Kahoots. Not really a fan of that. I just build it in PowerPoint. That's easier for me, but still works through the same thing. We're able to talk about the content and hopefully work through any issues. And then if you guys have questions as we're working through that, please feel free to let me know. I did post an announcement, I think on Thursday, that we'll use room 116. It's one of those new classrooms, a nice big classroom, should be able to spread out just a little bit. The biggest factor really is that it's not those weird shaped trapezoid or whatever tables. So I think that will definitely help. So we'll do that tomorrow. All right, so let's finish up chapter 8. Or unit 8, a lot of the things that we have talked about already that predispose or give bigger risk factors. Am I breaking up? I hear. Okay, let me try turning off my camera and see if that helps. There are, some rain clouds in the sky, and that typically is how it goes. Does that make it any better if I turn my camera off? Still breaking up or okay? Okay, no, it didn't make it any better, or I'm still breaking up.
It's better.
Okay, cool. All right. So when we're talking about factors in our GU dysfunction, a lot of the things that we have talked about fit into the same category, right? Our physiologic, our anatomical parts are smaller, much like we talked about with our airway. So when we have things that block that urinary pathway, it can come to a point where it causes an infection from that blockage. Okay. We've also talked about how conditions can be congenital, meaning that we are born with it or acquired. So we'll talk about some examples for both of that. Okay. All right. So when we talk about some of our major differences, oh goodness, I'm sorry. There we are. When we talk about it from a physiologic standpoint, first our nephrons, right? We know that they are supposed to help us remove waste in our body. I don't have anyone in my waiting room, Laura, so he may be in the wrong classroom. I don't have anybody listed right now. So they're not as effective. They're not functional at removing waste. So when we have things that are kind of slow to remove, it can increase that likelihood of infection. Okay. Our bladder capacity is also small or much smaller than we see in our adolescent, our adult. So that can affect their ability to get rid of those pathogens or potential infection causing agents as well. Okay. The immature kidney function, when we talk about trying to excrete things, whether we're talking about pathogens or medications or anything like that, it can be an issue. Okay. Bladder control is not something that we see until late toddlerhood or really solidified with no accidents happening until later in childhood. Okay. This is a great time to talk about toilet training. You may have a couple questions on your exam tomorrow about how would you know, or what advice would you give to caregivers regarding is it time to start potty training with my child? There are a couple things that we need to look at. Okay, so first we've got physical readiness. This is manifested in that child having that voluntary bowel and bladder control. Typically, this happens around 2 to 3.5. Okay. We can start providing that education, if we're vocal about changing diapers, if we're saying things like, oh, do you have poop, or do you need to use the bathroom, or however, your family chooses to word it. It helps kind of make that neurologic connection with that patient or with that baby, that child, that when I feel like this is when my diaper gets wet. So early signs are just trying to have that vocal ability. Okay. As we continue on, we see some physiologic changes, like the ability to stay dry for at least 2 hours. During nap time, we put them down with a dry diaper. If they're still dry when they get up, that may be a good sign there. Decreased number of wet diapers, waking up from the nap dry, like we already talked about. When they get to a regular bowel movement where it happens specifically, at a certain time of day, that may be a good time as well. When they get those fine motor skills to actually be able to take off their clothes, knowing that that's going to be something that down the line they would need to be able to do by themselves. Okay. That mental readiness, really helping them understand that urge. So vocal coaching can help here as well. The desire to imitate the behavior that they're seeing. A lot of children, especially starting at a very young age, are very curious to what goes on in the bathroom. My son, for example, literally follows me every single time I go to the bathroom, with just that, neurologic curiosity of what is my mom doing in here. Okay. Then we get to the psychologic readiness. All right. This is where the children are really able to verbalize the need to go to the bathroom. They're willing to sit on the toilet for a couple minutes without really fussing. They're able to talk about what happens when they need to go to the bathroom. Those are all great signs. And then the last category we have is parental readiness. Potty training can be a really frustrating time for parents, especially if you have working parents or parents who are sharing the caregiving responsibilities, because not everyone has that same ability to pay attention or to really recognize these cues. The best advice that you can give to caregivers is to really watch for that readiness, and to be ready to be consistent. So whether you are of the philosophy that we'll just keep the diaper off and I'll clean up whatever messes and hopefully that'll cue the child in, or we go to the bathroom every hour on the hour, trying to help that connection there, whatever path the family decides to go with, just kind of reinforce that consistency is the thing that's going to be the most helpful, and allow for the potty training period to be as short and as painless for everyone involved as possible. All right, so let's jump right into some of our infections. The first one we're going to talk about is a UTI. This is something we see across the lifespan spectrum in our patients. Just like in the adult patient, the E. coli is the most common organism. Typically what we're seeing in our pediatric patients, especially our young pediatric patient, is either there is a anatomical issue that is causing that E. coli to make its way into the urinary tract, or we've got poor hygiene. Okay, if we're seeing it in the older child, it may be poor hygiene as well, just maybe that lack of education on how to keep themselves clean, how frequently to bathe, and that kind of thing. Okay, the same information that we provide for older children and for adults about preventing urinary tract infections, wiping front to back in our female patients, keeping things as dry as possible, changing out of swimsuits in a timely manner, frequent diaper changes, all of those cotton panties, etc. All of those things are still things that we would want to provide as far as education here, because those can still be risk factors. Okay. Some of the manifestations that we see in the pediatric period, if you had a child who was previously potty trained or toilet trained, we may see that incontinence. Okay, that comes from some of that frequency or urgency that we see. They're really just not able to make that connection. They don't get that signal fast enough to get themselves to the toilet before that accident occurs. Okay, may also see anorexia. Anorexia pops up in a lot of conditions with our pediatric population. They don't feel well, they just don't want to eat. Okay, persistent diaper rash isn't really a side effect, but maybe something that we see as part of that infectious breeding background. Okay, crying on urination because it may burn depending on what our pathogen is. All right, we're going to diagnose this just the same way that we would. We do a UA to look at some of our sediments, see if there's white blood cells, that kind of thing. And then we follow that up with the culture. We're most likely going to start some broad spectrum antibiotics in our pediatric patient that is showing signs of a UTI, waiting for that culture to come back. And then if we need to make adjustments based on the pathogen, then we can do that. The whole idea with that infection, especially if we're looking at an infant, is it can take over very, very fast, get from the urinary tract into the bloodstream or whatever infection we may be looking at. And we want to start killing that bacteria, even if we're not using the most effective tool. That broad spectrum antibiotic for that first 48 hours can help decrease some of those symptoms, prevent some bacterial growth until we get something that's more specific. Okay, so for our management, we're going to eliminate that current infection. Our goal is to start those antibiotics early if we're looking at a bacterial infection, trying to prevent that from going from our urinary into our bloodstream or CSF, some other body fluid. And then we provide education. So if there's certain risk factors that we're seeing, that poor hygiene from wiping or not changing diapers enough, or if it's something more along with the child where they're holding their urine because they're enjoying playing or something like that, we know that urinary stagnation can increase our likelihood of developing an infection. So providing that education. At that point, it's going to be more on the parent or the caregiver to remind that child to stop playing and go to the bathroom. But as that child continues to mature, they'll be able to make those changes on their own. Okay. All right, urenesis is our fancy term for bedtime or nighttime wetting, bedwetting. We often see this, we have children who are potty trained and then we see this resurgence. So it can be a structural factor, can be secondary to a UTI from that need, that frequency, that urgency that we just talked about, maybe related to some neurologic factors, could be an indication that we've got early diabetes starting, most likely either diabetes insipidus or type 1, which we'll talk about in a couple weeks, could be chronic renal failure. The other thing that's not listed here is that it could be psychological, and we'll talk more about that in just a second. Okay, so what happens? It's involuntary passage of urine. Most children don't just lay there in the bed and say, I'm just going to wet my bed because it's easier. It's something that just happens. Okay, so they go to bed, they either don't get that signal strong enough that they need to get up and go to the bathroom. It doesn't wake them up from their sleep, or they're just not aware that it happens. Okay, so if it's related, typically, this is a conversation that a parent or caregiver would have with the parent, and try to, with the pediatrician, would try to get some information. How often is it happening? Is the child voiding before he goes to bed? What is the fluid schedule? When do you stop? Does he have a full glass of water right before bed? Because all of those can be factors. So we typically start with those behavioral signs first, unless it seems like more is going on with the story. Okay, if there's other symptoms, This can also happen if there is a stressful period, the family's moving, there's been a divorce, or there's some kind of big change like that, can also be related to stress. So the more information that pediatrician or that nurse can get from the family, the more likely they're able to decide, is this something that's more psychological, or do we need to do some more diagnostic testing? Okay, based on that information, the healthcare team would decide, do we just try these behavioral changes to see if this helps, or are we thinking that there's a bigger issue, something anatomical or infection related? Okay. All right, the next syndrome we're going to talk about, or the next disease process, is called nephrotic syndrome. Okay, so you can see our big criteria there. We've got proteinuria, hypoalbuminemia, hyperlipidemia, and edema. Okay. So from a pathologic standpoint, this can occur as idiopathic nephrotic syndrome, meaning we don't really know what caused it. It just happens. Could be childhood nephrosis as well. Can also be secondary to glomerular damage. What happens, our glomeruli are supposed to help move our plasma proteins through. Can also be an autosomal recessive disorder present at birth. So it can be congenital as well. This is not typically one of the things that we're going to screen for on that newborn screen. Wouldn't be part of any routine testing in most states. If the parents said that there was a family history either from them or deeper into the family, it may be something that we test for if we start seeing some symptoms. Okay, so what we see happen, you can see our clinical effects there, but what happens is we've got that increased glomerular permeability, meaning that things are easier to move into those sorry, that's such a hard word for me to say, into those glomerulars. That increases urinary protein loss, and we see that manifested in those categories there, that proteinuria, that hypoalbuminemia, hyperlipidemia, and that edema. Okay, basically we've got this massive fluid shift, and we're seeing that manifested in these ways. Okay, may also have that anorexia, child just has no interest in eating, maybe irritable. Typically that is related to the imbalance of electrolytes and other minerals that we're seeing there. The labs that we would do here, we're going to do a urine analysis. We'll probably follow that with a urine culture as well, just to make sure that it's not infectious related. But the bigger things that we're going to see is that protein in the urine, and in our blood panel, we're going to see that low levels of albumin, high levels of lipids, and then physiologically in our assessment, we're going to see that edema. Okay. All right, you can see a nice sequence of nephrotic syndrome here. We have that damage to our glomerulus that causes that massive proteinuria. All of that protein is spilling out in our urine. That is what leads to low levels of protein in our blood. That is then affects our liver. We see that hyperlipidemia manifest. Also from that low level of protein in our blood, that affects our oncotic pressure, which is the way that our fluid moves through our body. That leads to systemic low levels of volume or hypovolemia. We can see that cause decreased renal blood flow. So we've got potential kidney damage that can happen here. We've got increased secretion of ADH and aldosterone as that body tries to compensate for that fluid shift. All of that manifests into that physical edema that we can see in our patient. Okay. All right, so what are we going to do for our patient here? First, we want to decrease the amount of protein that we're spilling out in our urine. Okay. We also want to reduce the edema and prevent any type of infection. Because of all of that fluid shift, the body may have that desire to hold on to fluid to try to balance out. So that may increase the likelihood of a UTI or kidney infection because the body holds on to that urine. Okay. Put the child on a low sodium diet to help decrease the amount of edema that we may see. Diuretics sound a little counterintuitive here because we're already losing lots of fluid, but because that body is going through that compensatory mechanism trying to hold on to the fluid, we're actually going to try to flush out the system so that we can try to rebalance in a more normal level. Okay, those steroids are going to help with inflammation. We do see relapse in about 2 out of 3 children, so about 66%. So definitely something we want to provide education for as we're sending our parents home. Strict INO is going to help us manage our input and output, make sure whatever we're putting into that body is what we're getting out. Daily weights will help see how effective those diuretics are. Urine dipstick to follow that albumin. We'll monitor our vital signs because that can be an indication that our electrolytes are getting unbalanced. And look for edema. Remember, in our pediatric patient, we see it most frequently in the thinnest of tissues. So areas like under the eye, that periorbital edema, and our genitals is a very early place that we can see it as well. And then as that edema increases, we'll start to see it in bigger tissue, such as, ascites in that abdomen. Okay. All right, the next condition we're going to talk about is AGN, or acute glomerulonephritis. Remember when we talked about cardiac, we had that rheumatic fever that's often secondary to that strep infection. This is another infection that's typically secondary as well. Okay, so we have that latency period. The strep throat happens, and then sometime between 1 to 3 weeks later, we may see this in our child. Okay, not really sure what causes it to go from that strep throat, or if we have an isolated incidence. We don't really have the research to show why some children are more at risk. But you can see the thought process is that we have that immune deposit that the body mounts that infection against the strep throat or whatever primary infection happened. The body tries to mount that response, that infectious response systematically, and we can see those glomeruli, as they're trying to protect themselves, get inflamed or edematous, which can decrease the body's capability of filtering out bad bacteria. Okay. So that decrease in filtration increases that sodium and water, which is what we see in that edema as it manifests. But because the body's holding on to that water, we have the increased likelihood of developing an infection in this area. All right, so how we see this manifested, we see oliguria, edema, hypertension related to that damage that's being done to the kidneys. Also may see some blood and protein in our urine. We're going to do that ASO titer. Remember, that's going to tell us if that strep infection is present in the blood. Most of our care is going to be supportive here. Okay. If our vital signs are stable, we're not seeing major, high blood pressure, or any major vital sign changes based on the electrolyte imbalance, we can treat this patient at home. Okay. We're going to restrict sodium just like we did with that nephrotic syndrome. May have to restrict fluids while that body is fighting to rebalance levels. Okay. Again, with the strict INO and daily weights, we'll do those vital signs every 4 hours because the changes, especially in that blood pressure, can happen very quickly. Unlike that nephrotic syndrome, this is typically a one and done. We don't see frequent or reoccurrences in our patients with this one. Okay. So UTI, I feel like if we're looking at all the different syndromes that you need to be familiar with here, UTI, we see a lot of the same things that we see in our older population, our adult population. Okay, so the big change there would be potential urinary accidents, which does happen in our older elderly population as well. But a lot of the same things that we see related to that UTI are going to be the same across the lifespan. All right, the two that I feel like you need to pay attention the most to prepare you for your exam tomorrow is going to be nephrotic syndrome and this AGN, this acute glomerulonephritis. Okay, so the last two slides that we have here are some great ways for you to look at the differences. So like I've said in our previous lectures, look for the things between these two disorders that are the most different. Okay, so with both of them, we talked about, we talked about that edema. That's not going to be something that's going to help you pick apart, is it AGN or is it nephrotic syndrome? Okay, so you can see the ones that are highlighted, that hematuria, the blood pressure, pain, serum albumin, and the H&H. If you're looking at these questions, whether it's on this exam or in the future, NCLEX, et cetera, these are the things that are going to be the most different. So they're going to help you differentiate, is it AGN or is it nephrotic syndrome? Okay, so with that hematuria, it's significant in that AGN, and we don't typically see that in nephrotic syndrome, or if we do, it's very mild. Okay, blood pressure, especially that high blood pressure, we associate more with that AGN because it's related to the damage that's going on with our kidneys. Okay, the pain is a big factor as well. With nephrotic syndrome, it's related to the pain that we get from that skin stretching, the pressure that we get in wherever our edema is happening. With the glomerulonephritis or the AGN, we see some related to the headache, which the older child may be able to share with you. That albumin is another big factor. So in AGN, it's only minorly decreased, but nephrotic syndrome, we said that was one of our big red flags there when it comes to our lab work. And then H&H is increased in our nephrotic syndrome and can be normal or decreased in our AGN. Okay, so when you're studying for this, and I mean, this is the last of the new information that's going to be covered on your exam, I would pay the most attention to the things that you see markedly different, because that's really going to help you when it comes to determining, is this AGN or is this nephrotic syndrome on your exam? Okay, the last slide is about what you're going to do, the nursing interventions related to those two. So again, look for those things that are different. So you can see I&O and weight, that's strict and daily for both patients. Okay, positioning, we still change that every 2 hours. We're looking for that skincare that's related to the edema, the increased pressure that's being put on those areas. Activity is as tolerated. Those are the same across the board. Okay, so look at the things that are different. Okay, so AGN and nephrotic syndrome, we wanted to do low salt on both, but on nephrotic syndrome, we also want a high protein because we're spilling out all of that protein first in our urine, but also in our blood as well. So we need to replace that. Okay, with AGN, we have that fluid restriction because we're trying to let the body balance out its own water. Nephrotic syndrome, we actually go the opposite. We're trying to flush the system because we don't want that the body's not doing enough to compensate. Okay, medications is the last thing that we see different as far as our nursing interventions, because AGN has that tied to hypertension. We may have to give some antihypertensives. We also give the diuretics and antibiotics because AGN is typically related to that strep infection, right? It's secondary. Okay, diuretics are also going to help us flush out that system, help us balance. And then nephrotic syndrome, the corticosteroids we talked about helps reduce that inflammation immunosuppressive agents if we think this is related to the body's immune response, where we're having that exaggerated response, diuretics to help flush out the system, and then albumin to replace what we're losing, antibiotics if we have a secondary infection. Okay, so really pay attention when you're studying for this exam to those things that are different, because that's going to help you determine what you're going to do. You may have question could be about nephrotic syndrome. You may have had to identify in your question that that's what's going on, but based on that deduction, I'm dealing with nephrotic syndrome. I know that this is what I'm going to have to do about it. So it's important that you guys get these big differences here. Okay, so that is the end of the GU section. Anybody have any questions about what we've just covered? No. All right, let's take a quick 10-minute break. We'll come back at 8:13. I'm going to go reset my router. So it may, if it closes the Zoom room, I'll open it right back up.
Ms. Bennett?
And see if I can get, it's easy.
Professor Bennett?
You guys.
Professor Bennett, can you hear me?
I can hear you.
Okay, so these slides that you have highlighted here, they're not in our original slide list, like highlighted. These are yours, correct?
Yes.
Okay, and these are going to be up on an announcement or something, so we can go over those?
No, but I'm recording this so you can go back and look at them.
All right, thank you.
Any other questions? Okay, let's come back 8:13 and we will start our review.